Before we begin, this discussion is for medical education only and should not be interpreted as individualized medical advice. Welcome to Nephrology Notebook. Today we're reviewing REDUCE-IT, a landmark cardiovascular outcomes trial of icosapent ethyl in statin-treated patients with elevated triglycerides and residual cardiovascular risk. Any patient case used here is hypothetical and for teaching only. The central question is practical. When LDL cholesterol looks controlled, can residual risk still be modified with an evidence-based adjunct? REDUCE-IT showed a major reduction in ischemic cardiovascular events with high-dose icosapent ethyl, but the key teaching point is nuance. The benefit was not fully explained by triglyceride lowering alone. Proposed mechanisms include effects on lipid particles, inflammation, thrombosis, membrane biology, and plaque behavior. But the trial did not prove one dominant mechanism. So the headline is not "Fish oil works." The headline is "Selected high-risk statin-treated patients may benefit from prescription EPA." Let's anchor this in a hypothetical teaching case. Patricia is 64, has type 2 diabetes and prior myocardial infarction, and is already on a maximally tolerated statin. Her LDL cholesterol is 74, which looks controlled, but her fasting triglycerides are 216. That creates a familiar clinical tension. The LDL box is checked, but the patient's overall atherothrombotic risk is still high. Next, we'll unpack why that matters. After statins, clinicians often ask what comes next. Fibrates, niacin, and mixed omega-3 supplements have not consistently delivered incremental ASCVD outcome benefit in broad statin-era trials. REDUCE-IT addressed a different question: whether purified prescription EPA at high dose could reduce events in a selected high-risk population. LDL-C optimization remains foundational. Icosapent ethyl is an adjunct, not a substitute. A controlled LDL does not mean cardiovascular risk has disappeared. Residual risk includes triglyceride-rich remnants, inflammation, diabetes, blood pressure, smoking, CKD, obesity, and sometimes LDL-C that is still above a patient's individualized goal. REDUCE-IT used triglycerides partly as a biomarker of this residual risk environment. The key shift is from treating a single lab number to recognizing the broader atherogenic context. Elevated triglycerides often travel with triglyceride-rich lipoproteins, remnant cholesterol, endothelial dysfunction, oxidative stress, and inflammatory vascular biology. But REDUCE-IT should not be interpreted as proof that simply lowering triglycerides explains the outcome benefit. Instead, triglycerides helped identify a group with residual atherogenic risk. That distinction is essential, because not every triglyceride-lowering therapy has improved cardiovascular outcomes. Think of the vessel wall as an active inflammatory environment, not a passive pipe. Triglyceride-rich lipoproteins, macrophage infiltration, systemic inflammation, and lipid core expansion all contribute to plaque vulnerability. REDUCE-IT fits into this framework because EPA may influence several pathways beyond triglyceride lowering. For teaching purposes, the phrase to remember is, residual risk is biology, not just arithmetic. Before REDUCE-IT, the field had already learned a hard lesson. Improving lipid markers does not guarantee fewer clinical events. Broad add-on trials of niacin, fibrates, and mixed omega-3 products did not consistently reduce cardiovascular outcomes in statin-treated populations. These therapies may still have roles in selected settings, such as severe hypertriglyceridemia, but outcome evidence is different from lipid-lowering evidence. This is the therapeutic gap REDUCE-IT tried to address. On one side, we have aggressive statin therapy. On the other, we have comprehensive risk factor modification: blood pressure, glycemic control, smoking cessation, weight, diet, and exercise. But selected high-risk patients remain vulnerable. REDUCE-IT asked whether adding high-dose prescription EPA could close part of that gap with hard cardiovascular outcome data. This distinction matters clinically. Over-the-counter fish oil supplements are variable mixtures of EPA and DHA with inconsistent purity, dose, and oxidation profiles. They should not be treated as interchangeable with prescription icosapent ethyl. REDUCE-IT tested purified EPA ethyl ester at 4 grams per day. So when discussing the trial, avoid saying fish oil reduced events. More precise wording is high-dose prescription icosapent ethyl reduced events in REDUCE-IT. EPA may alter membrane composition, lipid packing, cholesterol domain behavior, and plaque biology. These are biologically plausible mechanisms, but they remain proposed explanations rather than proven mediators of REDUCE-IT's benefit. The trial was designed to test clinical outcomes, not to isolate a single molecular pathway. So the teaching point is cautious. REDUCE-IT supports outcome benefit, while mechanism remains uncertain. Several downstream effects have been proposed: improved endothelial function, reduced oxidative stress, anti-inflammatory effects, and lower hepatic very low-density lipoprotein production. Some analyses also suggest the benefit was only partly related to triglyceride reduction. But again, mechanism is hypothesis generating. The practical conclusion is not EPA works because of one pathway, but rather that the observed benefit likely reflects multifactorial biology. Mechanism cuts both ways. If EPA influences membrane dynamics, atrial electrophysiology, or platelet pathways, then safety signals deserve attention. In REDUCE-IT, hospitalization for atrial fibrillation, or flutter, was higher with icosapent ethyl. Serious bleeding was numerically higher, though not statistically significant in the primary publication. Clinically, that means reviewing AF history, anticoagulants, antiplatelets, bleeding risk, procedures, fish allergy, and pregnancy or lactation status. REDUCE-IT did not emerge from nowhere. JELIS, conducted in Japan, suggested that EPA added to statin therapy could reduce major coronary events. But JELIS was open-label, used lower-intensity statin therapy, and involved a Japanese population. REDUCE-IT then tested a more modern question. In a multinational, statin-treated high-risk cohort, does 4 grams daily of purified EPA reduce residual cardiovascular risk? REDUCE-IT was a Phase 3b, multi-center, randomized, double-blind, placebo-controlled trial. It enrolled 8,179 patients across 473 sites in 11 countries. Patients received icosapent ethyl 2 grams twice daily with food or mineral oil placebo, with median follow-up of 4.9 years. The trial was event-driven, and endpoints were independently adjudicated. A major critique is the mineral oil placebo issue, which we'll address later. The REDUCE-IT population was not anyone with high triglycerides. Patients were statin-treated, had controlled LDL cholesterol, elevated triglycerides, and either established cardiovascular disease or diabetes plus another risk factor. The trial allowed triglycerides down to 135 milligrams per deciliter because of protocol allowance and variability. Current U.S. labeling is narrower in some ways, using triglycerides at least 150 and diabetes plus at least 2 additional risk factors. The enrolled cohort was high risk. Median age was 64. About 71% were secondary prevention patients, and nearly 58% had type 2 diabetes. Median LDL cholesterol was about 75, despite statin therapy, and median fasting triglycerides were 216. Most patients were on moderate or high-intensity statins. This is important because REDUCE-IT was not testing EPA instead of statins. It was testing EPA on top of statin-based risk reduction. The primary endpoint was a broad ischemic composite: cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, coronary revascularization, or unstable angina. The key secondary endpoint was harder and narrower: cardiovascular death, non-fatal MI, or non-fatal stroke. Independent blinded adjudication strengthens confidence that events were assessed consistently. When interpreting REDUCE-IT, always separate the broad primary composite from the hard 3-point composite. For the primary composite endpoint, event rates were 17.2% with icosapent ethyl versus 22.0% with placebo. That corresponds to a hazard ratio of 0.75, a 25% relative risk reduction, an absolute risk reduction of 4.8%, and a number needed to treat of 21 over a median 4.9 years. The key clinical message: this was not just a small biomarker signal, it was a meaningful trial-level event reduction. The key secondary endpoint, cardiovascular death, MI, or stroke, also favored icosapent ethyl. Event rates were 11.2% versus 14.8%, with a hazard ratio of 0.74 and an NNT of 28. This matters because the benefit was not limited to softer endpoints like revascularization or unstable angina. REDUCE-IT showed reduction in a harder ischemic composite, which strengthens its clinical relevance. The benefit extended across multiple ischemic endpoints in the pre-specified hierarchy: cardiovascular death or non-fatal MI, urgent or emergency revascularization, cardiovascular death, unstable angina hospitalization, and stroke. However, all-cause mortality was not significantly reduced. So the clean teaching point is, REDUCE-IT showed broad ischemic benefit, including cardiovascular death reduction, but not a statistically significant all-cause mortality reduction. Subgroup analyses did not show clear heterogeneity by baseline triglyceride level. Patients above and below 150 milligrams per deciliter appeared directionally consistent, but subgroup and attained triglyceride analyses should be interpreted cautiously because they are less definitive than the primary randomized comparison. The safer conclusion is that benefit was not clearly driven by baseline or achieved triglyceride levels alone. The safety trade-off is clinically important. Hospitalization for atrial fibrillation or flutter was significantly higher, 3.1% with icosapent ethyl versus 2.1% with placebo. Serious bleeding was 2.7% versus 2.1%, a numerical increase that did not reach conventional statistical significance in the NEJM report. Overall discontinuation rates were similar. In practice, this supports individualized risk review, especially in patients with AF or bleeding risk. REDUCE-IT had major strengths: large sample size, long follow-up, randomized double-blind design, international enrollment, hard clinical endpoints, and blinded independent event adjudication. It also tested a specific agent and dose, not a supplement category. The balanced critique is sponsorship and sponsor-managed data, plus the mineral oil placebo controversy. Those concerns should temper overstatement, but they do not erase the strength of the observed outcome signal. The mineral oil placebo remains the most debated limitation. The placebo group had small increases in LDL cholesterol and inflammatory markers, raising concern that placebo might have worsened risk markers. Post-hoc analyses have generally suggested that mineral oil is unlikely to explain the full magnitude of benefit, but uncertainty remains. So the fairest interpretation is, REDUCE-IT's effect size is compelling, but placebo-related artifact may have contributed in part. Icosapent ethyl fits as an evidence-based adjunct for selected high-risk, statin-treated patients with elevated triglycerides after LDL-C and lifestyle optimization. It is not a replacement for statins, smoking cessation, blood pressure control, diabetes care, weight management, or LDL-C intensification when indicated. REDUCE-IT is best understood as residual risk management in a carefully selected population, not a broad endorsement of omega-3 supplements. Returning to our hypothetical patient, Patricia. She resembles the REDUCE-IT population because she has prior MI, diabetes, controlled LDL on statin therapy, and fasting triglycerides of 216. Rather than recommending OTC fish oil or assuming LDL control is enough, it would be reasonable to discuss prescription icosapent ethyl as an evidence-based option. That discussion should include adherence, cost, AF history, bleeding risk, and shared decision-making. A practical way to teach this is to separate trial criteria from current U.S. labeling. REDUCE-IT included statin-treated patients with established cardiovascular disease or diabetes, plus at least one risk factor, with triglycerides allowed down to 135. Current U.S. cardiovascular risk labeling uses triglycerides at least 150 and diabetes plus at least 2 additional risk factors. The action word should be consider, not automatically initiate. 3 pearls. First, OTC fish oil is not equivalent to prescription icosapent ethyl. Second, triglycerides are not just a math problem. They can mark residual atherogenic risk, but mechanism is not definitively established. Third, benefit comes with trade-offs, especially atrial fibrillation and bleeding review. REDUCE-IT is powerful because it connects a high-risk phenotype to hard outcome reduction, but only in the right clinical context. The final takeaway. REDUCE-IT showed that residual cardiovascular risk is treatable in selected high-risk, statin-treated patients with elevated triglycerides, using prescription icosapent ethyl 2 grams twice daily. Mechanisms are likely multifactorial, and patient selection matters. For more landmark trial breakdowns in kidney and cardiovascular medicine, subscribe to Nephrology Notebook. As always, this content is for education only and is not individualized medical advice.